Setengah-tengah pun. I don't hear you.
Very good evening, everybody. I hope everybody can hear my voice. Oh, nice. So let the class starts, then we will talk in further. Let's wait for the people to join, and then we will start it up. Okay.
Hello, sir. You can start now.
Okay. Can you able to see the screen properly? If you could able to see the screen properly, just unmute yourself and say yes. So if you could hear my voice and see the screen properly, unmute yourself and say yes.
Yes.
Okay, much better. So today is a introductory session. So I'll be teaching for another 2 hours. So be prepared. So the topic we're gonna see most of the time is going to be the internal medicine, especially on the neurology and the neurocritical care. I hope you guys are all familiar with the topic and the basics. So we will proceed with the lecture on eventually, like how we are doing it. So I also wanted to know, shall we proceed with the classes now? If so, just say yes. So I want to hear from you once again, one last time. It's a one final check. So I will go for the session directly. One final voice check. If you could hear my voice and see the screen very clearly,
Yes, sir.
just yes. Okay. Okay, much better, people. So speaking about this, so the topic we're going to talk about here is the neurology. It's a writing based lecture, so I want you to grab a pen and paper with you guys, or maybe the iPad or digital version, however you want, and you can write it along with me or follow it along with me. So, speaking about the neurology, the very first area we're going to speak in the neurology is the functional organization of your brain. So, how does your brain has been organized, and how the motor system functions and the sensory system functions? We will just start it. What is the functional unit of your nervous system, people? What is the functional unit of your nervous system? Very basic. What's the functional unit? Let's make it more interactive. I want you to speak a lot, so you will learn a lot. Yeah, very good. Neuron. So speaking about the neuron, we are going to draw the structure of neuron here. The neurons are composed of two major structure. What are they?
Cell body and axon.
Yeah, very good. Cell body, and with the one long projection called as axons. Cell body plus axons. Very good. So speaking about the cell body, we are going to talk about the very basic definitions here. So the collection of cell body is called as what? Collection of cell body is called as what? The collection of cell body is called as, very good people, come on, go.
Ganglion.
Ganglion, very good. But the collection of cell body which performs one similar function is called as ganglion. And the collection of cell body generally called as gray matter. Okay. The collection of cell body generally called as what? Gray matter. Well, similarly, we're going to push it up here. Collection of axon is called as opposite to gray matter.
White matter.
Yes, exactly. Collection of axon is called as white matter. Well, collection of cell body is called as gray matter. And the collection of cell body which performs similar function, is called as ganglia, as you said. Ganglia. Ganglia or ganglion. Okay. And similarly, collection of collection of axons which perform similar function is called as what is a collection of an axon which performs the similar function? It's called as tract. What do we call it? Tract. Okay. So in the cell body, okay, may I move the slide?
Sure, sir.
Okay. So in the cell body, we have the cell body is similar to that of the normal cells. So it was having a normal cellular organs like ribosomes, mitochondria, and all. Additionally, it have a multiple small projection which is called as dendrites. Okay. Additionally, it has a multiple small projections called as dendrites, and the area where the cell body attached with the area where the cell body attached with the axon, we call that as an axonal hillock. What do we call it? Axonal hillock. The summation potential which you study in the physiology occurs in the axonal hillock, one of the MCQ. Okay. So cell body have a numerous small projections and one single large projection. And this one single large projection is axon. The cell body portion where it gets attached with the axon is so called as axonal hillock, where the summation potential gets occurs here. Okay, then the potential have to travel down to the axon, but the axons are insulated by a specific sheath. The axons are insulated by a specific sheath called as, what is the sheath?
Myelin sheath.
Myelin sheath.
A myelin sheath. Very good, people. The sheath which is insulating over the axon is so called as myelin sheath. And this myelin sheath is formed by in the CNS what cells, in the PNS what cells. In the central nervous system, it is formed by the neuroglial cells called as oligodendrocytes. Oligodendrocytes. And in the PNS, it is formed by, come on, I'm writing it. Schwann cells. Very good. Okay. Is the myelin sheath is continuous? No, it is not continuous. It is separated by a nodes of
Ranvier.
Ranvier. It is separated by the nodes of Ranvier. And now we have this axon. At the terminal portion of the axon, we have the axonal bulb. And this axonal bulb is containing the numerous amount of smaller vesicles called as synaptic vesicles. Okay. And this synaptic vesicles, whenever the potential has been generated and transported through the axon, based upon the potential received, this axon will, the ion channels will get infused, and based on the ion channels which has been released, the neurotransmitter or the respective neurotransmitter will be released into the synapse. So what is the synapse again, people? So let me put it in this way. So we have a one neuron, that is an axon of a neuron 1. Axon of neuron 1 is attached with the dendrite of neuron 2. The dendrite of neuron 2 via a function called as synapse. Okay, via a function called as synapse. So here what we will use to see here, whenever the potential has been generated, axon will release the neurotransmitter into the synapse. The neurotransmitter will bind with the postsynaptic receptors and creates the potential, postsynaptic potential. So this is how the connection between the one neuron to the another neuron occurs. So now here how the sensory neurons travels informations, sensory neuronal transmission. So from the periphery to the brain, yes or no? So from the periphery from the periphery, we have this peripheral receptors which receives the input and then transfer it to what order neuron? First order neuron, first order sensory neuron. Okay, from the first order neuron, it will be transported to second order neuron. And from the second order neuron, it will be transported to third order neuron. Third order neuron. And the first order neurons usually terminates at the spinal cord or medulla oblongata. Okay, spinal cord or medulla oblongata. We will discuss that in the spinal cord disorder more and more about how the neuronal transmission and what are the tracks and the cross section of spinal cord. We all discuss that. But right now we are going to discuss only the basics for 10 to 15 minutes. Then we will move on to the actual topic. Okay. Then the second order neuron terminates at the thalamus, and the third order neuron will terminate mostly at the primary somatosensory cortex. Where is this primary somatosensory cortex located? Where is this primary somatosensory cortex located, people? Exactly. The primary somatosensory cortex located at the pre-central gyrus or post-central gyrus? Come on, faster, faster. Broadman area 312.
Post-central.
Broadman area 312, which is a post-central gyrus. Okay. So if you are opening into the brain, let me explain. If you are opening into the brain, we have here the central sulcus. On the central behind the central sulcus, we have this post-central gyrus where you see the primary somatosensory cortex. Where you are seeing post-central gyrus. Okay, and in the pre-central gyrus, you will have the Broadman area 4 and 5, which is a primary motor area. Primary motor area. Okay, and here we have this area where you will see in the occipital lobe as the Broadman area 17 and 18. Okay, 17 is a primary visual cortex and 18 is a secondary visual cortex. Primary visual cortex and a secondary visual cortex. Okay, and then we have two more area here for the speech. Broadman area 44 and Broadman area 22, which is connected by this arcuate fasciculus. Which is connected by this arcuate fasciculus. Okay, and this Broadman area 44 is a Broca's area. Broca's area, and this Broadman area 22 is a Wernicke's area. Okay, so this is just a general organization and important prior sensory areas and motor areas. So in the similarly, if the motor neurons, we have that descending pathway, primary motor neuron, upper motor neuron will transfer the information from the primary motor cortex to the spinal cord, and lower motor neuron takes it to the periphery. Okay, so how the motor neurons is transferring? How the motor neurons are transferring? Sensory pathway we have seen how the peripheral receptors will taken up by first order neuron and drops it in the spinal cord or medulla oblongata, and then second order neuron carries the information from spinal cord or medulla oblongata and throws it into thalamus, while third order neuron or higher order neuron will takes up the information from the thalamus to the primary somatosensory cortex. So similarly for a motor neuron, we have the primary motor cortex which transports the information to the spinal cord via upper motor neuron, and then from spinal cord to periphery via lower motor neuron. Periphery via lower motor neuron. Okay, so what is this upper motor neuron and lower motor neuron, people? Okay. What is this upper motor neuron and lower motor neuron? Tell me the difference between the upper and lower motor neuron. What is the exactly? Now we have seen the upper motor neuron and lower motor neuron. No, what is that upper motor neuron and lower motor neuron? One people you can say me. So the neuron which transport information from the brain to spinal cord is which one? Upper or lower? The neurons which transports the information from the brain to spinal cord is upper motor neuron, while the neurons which transport the information from the spinal cord to periphery is lower motor neuron. Spinal cord to periphery is lower motor neuron. Okay, have you guys got it? Shall I move on to the next topic? So I'll be a little bit scrolling up. So you guys, if you didn't write it, I will write it for next 2 minutes. Okay, so we will proceed to the next one. Done. May I move? May I move the things? May I move the screen? Unmute yourself and answer it, people. May I move the screen?
Okay, sir. Okay. You can move.
Okay. Nice. And then the sensory neuron. Speaking about the sensory neuron,
Yeah.
may I move?
Yes, sir.
Okay. Motor neuron, may I move? Okay. Finally. Now, speaking about this upper motor neuron and lower motor neuron. Okay. In the case of the upper motor neuron, it's a very small topic, so we will discuss that here itself and we will move on to the stroke and epilepsy. So, upper motor neuron. So, weakness usually seen in the upper motor neuron as whole muscular group rather than the single muscle. Okay, weakness is associated with the whole muscular groups. Okay, but while in the lower motor neuron, you will see the paralysis of the individual muscles or a particular group of muscle. Paralysis of the individual muscle or a particular group of muscle. Okay, while similarly, the tone of the upper motor neuron will be high. So you will get a hypertonic muscle, hypertonia in upper motor neuron defect. And here you will see the hypotonia. That means a flaccid paralysis. Okay, here you will see the flaccidity. Here you will see the flaccidity, while here you will see the clasp knife spasticity. Okay, clasp knife spasticity. And here the muscle wasting is very, very minimal, but here the muscle wasting is severe. Okay, what about the plantar reflex? The plantar reflex will be extensor. Plantar reflex will be extensor here. I will write it here. Plantar reflex. The plantar reflex will be extensor here, and here it is a flexor. Okay, so plantar reflex will be the flexor here. So this is what the characteristic findings you will find it on the upper motor neuron and lower motor neuron defect, people. Okay, let's move on to this. Let's move on to the disorders. The only upper motor neuron disorders are primary lateral sclerosis. Associated diseases are primary lateral sclerosis. While lower motor neuron defect, you have a lot of things. So first one is Kennedy's disease. What is a Kennedy's disease? Which is a biochemical one. X-linked spinobulbar muscular atrophy is Kennedy's disease, where you will see the increased production of CAG triple unit. Okay. And number one is a Kennedy's disease. Number two is Tay-Sachs disease. What is a Tay-Sachs disease? Tay-Sachs disease is due to the hexosaminidase A enzyme deficiency, right? And similarly, you will have a GM1 gangliosidosis. GM1 gangliosidosis. These are all associated with the lower motor neuron. And also you will see the spinal muscular atrophy. Spinal muscular atrophy. Let me revise it, people, for you. Okay. I will say the feature, you will say the answers. Okay. So flaccidity is associated with. Flaccidity is associated with. Faster, upper motor neuron or lower motor neuron?
Lower motor neuron.
Lower motor neuron. Very good. And similarly, you will see this clasp knife spasticity.
Upper motor neuron.
Upper motor neuron. Similarly, a group of muscle involvement.
Upper motor neuron.
Very good. Paralysis of the individual muscle.
Lower motor neuron.
Lower motor neuron. Let me get into the Babinski. Extensor Babinski.
Upper.
Upper. Very good. And flexor.
Lower motor.
Lower motor neuron. Okay. Similarly, if we are speaking about the bulbar palsy, lower motor neuron is bulbar palsy, while upper motor neuron is a pseudo-bulbar palsy. We will discuss that later. Okay, and we will discuss about this amyotrophic lateral sclerosis and all the motor neuron disorders in the topic. Just because we are going into this area, I was just talking about it. Okay, now speaking about the stroke, let me begin with the stroke, people. So there are so many people approaches stroke in so many way. So now we are entering into the actual topic because we have done with the basics, very basics. So now we are going into the actual topic. So I rather choose stroke as a triple area. So we can proceed the stroke as stroke versus TIA versus traumatic head injury. I used to see this whole thing in this three perspective. Okay. Stroke versus TIA versus traumatic head injury. Shall we discuss the topic? Shall we discuss the topic? Yes? Shall I move on, people?
Yes.
Okay, very good. So I will give you a time for writing, but I want you to listen more and more now. Okay, because it is a topic of interest. Okay, shall we move on? So first thing we are going to talk about is TIA. What is a TIA? Transient ischemic attack. The more you talk, the more we learn. Okay, we are all like a group of people who are ready to learn, right? So you talk, you will learn. I talk, I will learn. And we talk, we both learn. We will talk. Shall we talk more, people?
Yes, sir.
Okay, much better. Much better. That's what I wanted. So let us talk. What is a TIA exactly? What is exactly the TIA? The expansion is transient ischemic attack. Yes or no? What is a transient ischemic attack? TIA is a sudden onset of focal neurological symptoms and signs lasting less than 24 hours. Okay. If it is more than 24 hours, it becomes a stroke. Okay. So I rather go for the definition as sudden onset of focal neurological symptoms or signs. Focal neurological symptoms or signs. Lasting less than 24 hours. How many hours? Less than 24 hours. So it's a sudden onset of focal neurological symptoms or sign lasting less than 24 hours. That is, the patient will be technically normal. Consider he is a patient. He's my favorite guy. Okay, he's the patient. He's technically normal, and all of a sudden he got this weakness, and then he got this angle of deviation of the mouth, and then he got this saliva, drooling of saliva, and muscular weakness. Suddenly, one side is not working. Sometimes two side is not working. So that is a neurological symptoms, and within a 24 hours, and within 24 hours, if he becomes normal, and within 24 hours, he become normal. That is so called as TIA. That is so called as TIA. So speaking about this TIA, the features of the TIA could mostly be unilateral weakness or sensory loss, aphasia, suddenly unable to speak, ataxia, gait disturbances, and some visual problems. Okay, visual problems could be anything. Okay, and some visual problems all of a sudden. Okay, so you got the patient with the TIA, and you will immediately see that you will see this patient with a sudden onset where the patient is not having a normal body walking pattern, that is ataxia, or maybe the patient unable to speak all of a sudden, or patient unable to feel it on the one side of the body, or a patient unable to move his whole size of the whole one side of the body. This is all happens in the home, and the patient rush to the hospital. While coming to the hospital, the patient will be absolutely normal. While coming to the hospital, the patient will be absolutely normal. Okay, in this situation, what you will choose? We used to name it as a transient ischemic attack. Okay, previously, whenever the patient comes to you with the transient ischemic attack, always try to check with the amaurosis fugax is there or not. Okay, what is the amaurosis fugax? Amaurosis fugax. FU, huh? Yeah, reason right. Okay. Yeah, go ahead, people. What is the amaurosis fugax?
It's temporary painless loss of vision.
Yeah, very good. Temporary painless loss of vision. The patient will feel like the typical words of the patient will be curtain falling in front of his eyes for 1 to 5 minutes, and sometimes it rarely goes up to 30 minutes. Okay, so amaurosis fugax is not only used to assess the TIA. There is also used to distinguish whether the artery is from the middle cerebral artery or not. Okay, the stroke sometimes can originate from the middle cerebral artery or anterior cerebral artery, right? So we can able to identify if the amaurosis fugax is present. It might be related to the middle cerebral artery syndrome. Okay, so as you said, it is very right. What was that? Sudden painless loss of vision, which lasts for 1 to 5 minutes. Yes. So I can write it here. The transient monoocular visual loss or sudden painless loss of vision. You can write it in an easy word. Why we need to go for this stuff? Sudden painless loss of vision lasting for 1 to 5 minutes, but rarely goes up to 30 minutes. Okay, rarely goes up to 30 minutes. Okay, so patient technically says there is a curtain falling on his eyes, so he couldn't able to see it out for some times. Okay, that is a common one. Okay, and what is the scoring we used to assess for the TIA? Nowadays, ABCD2 is not used, but previously the only scoring system we use here is a ABCD2. ABCD2 scoring. What is this ABCD2 scoring?
If for age greater than 60 years, and
Yes,
B for
very
blood
good.
pressure, it might be the greater than 140/90,
Okay,
or
very
C for
good.
clinical feature including speech disturbance,
Yes,
Another
very
one
good.
is unilateral weakness, I think.
Hmm.
And
Very good.
another
You are giving a
D for symptoms, or another D for history of diabetes.
okay, history of diabetes. So one D, another D. What was you saying? I forgot. I couldn't hear it clearly. One D was diabetes, another D was
Duration, sir.
okay,
Duration of
duration. Very
symptoms.
good. Very good, very good. So technically, we have this ABCD2 scoring. A stands for age, which should be more than 60, as you said. Very good. Okay. So since you guys are saying it, I'm just writing it, my job. So second one, you told BP. How much should be the BP? How much should be the BP
140
you are
by
saying?
90.
Very
Greater
good.
than.
Greater than or equal to 140 by 90. That is, or we can technically say, systolic should be more than 140, diastolic should be more than 90. Anyone. Okay, you get a 1 point. Okay. And C for clinical feature. Okay, clinical feature of the TIA. So if it is a unilateral weakness with or without impairment, unilateral weakness with or without a speech impairment, with or without a speech impairment, how much should be the score? You will get 2 points. Okay, you will get a 2 points. Okay, only speech impairment is there without any unilateral weakness. So you have the unilateral weakness, then it is 2 point. You will have only speech impairment without a unilateral weakness, then we used to call that as 1 point. Okay. Then we have the duration. A, B, C, D. D for duration. If the TIA duration is more than 60 minutes, then we give a 2 point. If the TIA duration is less than 60 minutes or 10 to 59 minutes, then we give a 1 point. Then we give a 1 point. Then you have the diabetes goes for 1 point. So how much is the total score? You count and say me. How much is the total score, people? Come on, it's on the screen.
9.
Hmm? So 8 or 9?
9.
It is
Total
technically
9.
7. You give either 2 or 1 on the C and D. So the maximum score could be 2, 2 plus 2, 4, 4 plus 2, 6, 6 plus 1, 7. Yes or no? On that 7, how much is indicating that the patient is having a high stroke risk?
4.
Yes, very good. So the ABCD2 score of 4 or greater than 4 indicates that the patient is having a high risk of stroke. Okay, and what it does justify the hospital admission. Okay, so in total 7, ABCD2 of more than 4, ABCD2 of more than 4 or greater than or equal to 4 indicates the high risk of stroke. Indicates high risk of stroke. Okay, people. So for the transient ischemic attack, we have seen the clinical features. We have seen the scoring system. But this ABCD2 scoring is not usually recommended in the developed countries like UK and the US. But previously it was used, but no longer recommended now. Okay. Now speaking about the referral criteria and investigation, what could be the normal investigations you do for this TIA? What could be the normal
MRI.
investigations we do for this TIA? Yes, come on, people.
MRI or CT?
MRI. What kind of MRI you will do? MRI, DWI. Okay, diffuse wedge imaging. Okay, MRI, DWI is the investigation of choice. And in case of suspected carotid, if you see that there is a carotid involvement is there, If carotid is suspected, then we go for the CT angio. Okay, then we go for the CT angio, or in case we can go for the duplex or MRA. Okay, duplex or MRA. If we suspect that, then you have to go for the treatment of choices, carotid endarterectomy. Carotid endarterectomy. Only if we suspect the carotid. Now, taking about this, we go for the next one, referral area for the stroke. So we know that now we know the features, now we know the scoring system, now we know investigation, MRI, DWI, and if there is a carotid involvement, then you have to go for the CT angio. Okay, and then now we go for the management or referral. Which one we want to go first? Management I go or referral criteria I go?
Management.
Management we go, and then we will talk about the reference. Okay, first. So speaking about the management. So consider the patient is coming to you with the TIA has been resolved. The TIA has been resolved. Then what you have to do is you have to start him on aspirin 300. You have to start him on aspirin 300 and then wait for the stroke specialist. And then you have to wait for the stroke specialist. Okay. Or if the patient is coming to you with TIA and he had seen with the stroke review has been done. If the stroke review has been done less than 21, stroke specialist has ruled out a stroke. So there is no further risk. Now the patient is coming to you, sir, I don't want to see the stroke specialist, I want to see you. So if the stroke specialist ruled out the stroke in less than 21 days, then you have to give aspirin plus clopidogrel, dual antiplatelet, single antiplatelet, clopidogrel. Okay, if it is more than 21 days, then you have to go for the clopidogrel alone. Whatever I'm following here, the medication is the NICE guidelines. Okay, if you want to have if you're following other guidelines, just refer to it or refer to the hospital protocol. Mostly we rely on the hospital protocols alone. Okay, and are we doing
So
only
what
this
is
aspirin?
SS review?
Stroke specialist.
Okay.
Okay, stroke specialist review has been done. In less than 21 days, you have to start him on aspirin plus clopidogrel. Okay, if it is more than 21, then it is a clopidogrel. Okay, and are we giving only that? No, you have to add the PPI as well as statins. You have to add the PPI plus statin. Okay, when do we refer this patient to the stroke specialist, people? Now let's go for the referral area. When do we refer this patient to the stroke specialist? When the patient is coming to you with the TIA, and that too within a 24 hours, immediately the patient is feeling the symptoms and is coming to you. What is the first thing you have to do? When we see the TIA, the patient is having a TIA, is coming to the hospital, immediately give aspirin 300, and go for the stroke specialist within 24 hours. Within 24 hours. Okay, consider the patient is in a remote area. Patient is saying like, no, sir, I'm not in the area, but I experienced this in 3 days or 4 days, or sometimes 10 days ago. Now I thought I will come to here, so I will see the specialist. In this situation, if the patient comes more than 7 days, refer within 7 days. The patient comes more than 7 days, refer within 7 days. Within 7 days. Okay, so what are the TIA things? So shall we revise the TIA, people, if you are okay with? Or you want to write? Shall you guys finish writing? Just if you finish writing, say yes, we proceed with the review. If you finish writing, just say yes, we go for the next.
Yes.
Okay, much better. Received 1. What about the others? All done?
Yes, sir.
Okay, much better, people. So shall we revise the TIA? So I want one person. I'll call randomly the person name. I want one person to say the definition of TIA. So I use the name here. So you have a lot of participants. I use the name here. How about Firoza? Firoza, can you tell me what is the definition of TIA? Let's discuss more and more. Come on, people, you guys have to talk a lot. If you guys are talking, then we will be more into the job. So come on, I can't see you guys. So just talk. At least somebody give me the definition of TIA. And nobody here gonna judge you, right? You know or you don't know, because we are all learning here.
It's a focal neurological defect.
Yes, very good. Sudden onset of the focal neurological defect, which is lasting. The timing is very important. Which is lasting.
Less than 24 hours.
Less than 24 hours. Very good, people. Less than 24 hours. Okay. So I want anybody to give me what is the scoring system we uses and what are the factors we uses for this. What are the components of the scoring system? What is the maximum score and how much should be minimum to predict the risk of the stroke? Come on, go ahead, people. I want one people to explain me what is the scoring system we uses for the TIA and what are their component and the scorings, what is the maximum score and what is the minimum score required to predict the stroke risk. Anyone?
Age more than 60, BP
Oh, yes, very
140 by
good.
90.
Okay, very
And
good.
C stands for clinical feature, that is
Yes.
unilateral weakness with or without a speech impairment. And, duration more than 60 minutes or less than 60 minutes.
Yes.
Scored accordingly. D stands
Yes.
for diabetes mellitus. Another
Okay.
D stands for diabetes mellitus. And
Okay.
scoring given A1 score, B1, and in clinical feature, it is decided whether a speech impairment is associated or not. If only a speech impairment is there, a score is 1. If associated with unilateral weakness, score will be 2. And regarding duration, if it is more than 60 minutes, it will be given 2. And if less than 60 minutes, the score is 1.
Very
And
good.
for DM, a score is 1.
Okay. So little
Total,
bit. Yes. Yeah. Total.
total
Yeah.
score
Go.
is 7. 7. And if a score is more than 4, this
High risk for.
implies high risk stroke
Yes.
and must be hospitalized the patient.
Very good, doctor, and thank you very much for explaining it nicely. So I wanted to say there is this unilateral weakness, we give 2 points. Okay, and speech impairment, we give 1 point. If the unilateral weakness is present, technically patient is having a 2 point. Okay, irrespective of whether he's having a speech impairment or not, if the patient is having a unilateral weakness, simply we give 2 points. But we see there is no weakness and only speech impairment is present, that time we give 1 point. Okay, anyway, we are not using the score system. And very good, and thanks for nicely explaining it. Okay, now we go for this investigation of choice. Speaking about this investigation of choice, what is the investigation of choice? Somebody go ahead.
MRI. MRI, DWI.
Yes, MRI, DWI. If we are suspecting the
carotid involvement, we do CT angiography.
Okay,
and
CT angio, MRI or duplex scan. And duplex scan, we proceed with the, if we suspect it, and if it is confirmed, then we go for the carotid endarterectomy. Okay. And what about this management? Anybody? Management, if the TIA has been resolved, I give you the scenario and you tell me what you are going to do and then what is the how you will do it. Okay, you are sitting in the ER and I am the patient. I am this 40-year-old male presenting to your ER with the complaining of a sudden onset of unilateral weakness and a sensory loss in my home. And now on the while traveling in the ambulance, it got resolved. Now I am coming to you. I am perfectly normal. My GCS is 15 out of 15 now. So my age is 40 and my BP, the vitals are 120/80, heart rate was 72 and my SpO2 was 98% on room air and respiratory rate was 16 per minute. So I'm coming to you, you have done the preliminary assessment. Now you tell me what you're going to do.
So we'll put
Anybody?
aspirin 300 mg and wait for a stroke specialist response. And if the review is done within 21 days.
Oh,
If
doctor,
the
you forgot to take me an image. I may ask you, doctor, how did you say I had a TIA? You're jumping
Sorry,
into the management. What I'm asking is, I'm presenting to your ER, you take the preliminary assessment, what would be the next step? The next step is always the investigations.
investigation.
To prove that I'm having a TIA. Now I had a TIA. Now I'm saying my MRI DWI is normal. And RBS, my RBS is technically speaking 246. You run me the HbA1c test, it was coming out with the 9.2. And now you are questioning me whether I am diabetic or not. I'm saying yes, I'm taking metformin 500 mg BID. Now proceed to me. What is the ABCD2 criteria score? Go ahead, people. Go ahead. I got my MRI DWI is normal. My diabetes, yes. I'm taking metformin 500 mg BID and my HbA1c is 9.2 with the RBS of 246 mg per deciliter. Okay. My BPs, you already have it. My heart rate, you already have it. My age, yes, very good. So what would be my ABCD2 scoring would be? One second, people, I got a call. Anyways, 1 second, stay online.
That's Sunday. Yay.
Yeah, I'm sorry, people. Sorry for the disturbance and interruptions. And so what would be my ABCD2 scoring, people? I gave you the things. I gave you the stuffs. Yes, come on, go ahead, someone. How old am I?
So what was the duration of attack? Was it
I told you I got
less
it in the home, but when I get into the ambulance, my symptoms has been relieved, which is technically 14 to 15 minutes.
than- So it is 1. So I
Yes.
think it is near about 3. 1
Okay.
plus 1. No, only 2.
Okay.
1 for diabetes and 1 for the duration. So the score will be only 2.
No, I had a unilateral weakness in my home.
Okay. So 3.
That
So
technically
unilateral
4.
weakness 2. Technically.
Technically
Yes.
4. You see this when we are studying it is very simple, but when we are applying it, it becomes like a very much twisted, right?
Yes.
When we are experiencing the practical situation, that is where the twist comes. But when we are studying, we casually studies age more than 60, blood pressure of more than 140 over 90, and clinical features. Yes, this is what we are going to do in this upcoming days, that we are going to teach you not only the concepts, I'm going to teach you how to apply it. Very sorry, people. How to apply it over the normal situations. Okay, so that you will be mastering it when the patient is coming to you. So now I'm the patient who has come to me, who had presenting to you with this following features, and these are the things which we have been expecting. Shall we move on to the next case or the next patient, if it's okay? Shall we move on to the next patient, people?
Sir,
Okay.
it was sport 3 or 4.
It is a 4 because I got a unilateral weakness.
Unilateral.
Check with the ABCD2 scoring. I had a unilateral weakness in my home.
That is 2, sir.
Yes.
Weakness 2, diabetes
Yes,
1
2.
and 1 4.
My duration
4.
is
Yes.
less than 15 minutes.
So it is 1.
Yes.
1,
So
1 and 2. 4.
for
Total 4.
duration, 1 for diabetes, and 2 for the clinical features. You understood that?
Yes. Yes.
Yes, sir.
Yeah. So now I'm presenting you with the next patient. He's a 60-year-old woman. She was having a sudden onset of visual impairment. She's thinking like all of a sudden I couldn't see for 5 to 10 minutes, doctor, and I'm having. I was really scared, and she's presenting to you with the ER. What is the next thing you will do on this patient?
Sir, please repeat again.
Repeat the question. Miss.
The patient is a 60-year-old woman presenting to you ER, and she's saying, "Sir, I was all of a sudden, I got this, my eyes is not working. It's suddenly blocked. I didn't see anything on my right eye." Okay, all of a sudden she's saying, I can't see anything on my right eye. And she's presenting to you to the ER. And what is the next step you will ask? Next thing you will do?
Investigation in which MRI DW.
Do the ABC, people. You are the ER guy. When you are in the ER, the next question you will see is, do you still have a symptoms? If you have a symptoms, check the vitals. Okay. Now let me put you on the vitals. Okay. What could be her vitals? Her BP was 170 over 110, and she is having a heart rate of 104 over per minute and respiratory rate of 21 per minute, and she's having a saturation of 99% on room air. This is her vitals. How are you going to manage it? What's the next thing you will do? What's the next thing you will do? RBS. You will ask for the RBS. I'm saying her random blood sugar is 198. So you send for HbA1c, or you ask her she is diabetic. She's saying she's not diabetic, and her HbA1c is 5.2. And you ask her, when did you take your last meal? She says like around 30 minutes ago. So what's the next thing you will do? Now come back. What is the next thing you will do?
The duration is still unknown. From the duration is still unknown since she had the attack.
Okay. So consider my home is like 10 minutes from here. I'm still here.
Okay, so 10 minutes.
Hmm.
1.
You have to do that all in a minute.
5. 5.
Now,
The score will be 5.
Now you have to send her to investigation and then you will now assess. Now you are sending her to MRI DWI and now you are assessing the ABCD2. Tell me her ABCD2.
5.
So ABCD2 score is 5. She may have a stroke. Now her MRI report comes in. Let me jump into the next area, which is little bit interesting. Now you are jumping into the MRI or CT scan. And the CT scan is showing, or the MRI is showing, there is a stroke, especially on the areas which is supplying the TIA. MRI confirmed it. What is the MRI confirmed? Stroke on the MCA territory. Yes or no? Stroke on the MCA territory and the patient symptoms is matching. Amaurosis fugax. Yes or no? So this patient is having a TIA or stroke?
Yeah.
No, stroke. Because patient is still having the symptom. Patient is still having the symptom. Investigation has been confirmed. Yes or no?
Yes.
You can't always think your brain with the TIA when the patient is coming to you. You have to think all the possible ways and then you have to eliminate one by one. Okay.
So what
now
was the
we
full
got
form of DWI?
TIA, DWI, diffuse wedge imaging. Diffusion wedge imaging or we can call it as diffusion weighted imaging. Anything you can say. Okay. The diffusion will be more in the case of your MRI. Typical MRI with the MRI DWI, the diffusion weight will be more, little bit. That's it. Okay, so consider you are having a patient with the acute stroke. Now we go to the algorithm of the acute stroke. So we got with the TIA. So TIA, I want one person, anybody, to explain me what are the TIA, what is the patient symptoms, how they will present, what is the duration, what is the scoring system, and what is the management, and what is the referral criteria. Faster and faster, like in a one word. I want one people to explain me in 2 minutes. So I will move on to the next area. For the stroke.
Sudden onset of local neurological symptoms or signs lasting less than 24 hours.
Very good.
Clinical
Next.
features, unilateral weakness, sensory loss, maybe aphasia, ataxia, visual problems, maybe sudden temporary paleness, loss of vision.
Okay.
And which may, if it is TIA, that may last for 1 to 5 minutes.
Yes.
And
Okay.
a scoring system ABCD2. A stands for age, B stands for BP, C stands for clinical feature, D stands for duration, and another D stands for diabetes mellitus. Diabetes.
Okay, that is enough.
And
we can go for the next investigation and management.
Investigation.
Yeah, go ahead for the investigation.
MRI, DWI, diffusion with imaging, and if there is a stroke and carotid is involved, then we will do CT angio, duplex MRA, and whether we can find carotid in that arterectomy.
Okay. What about the management and referral?
Management, if it has already been resolved, then we'll give aspirin 300 mg and wait for a stroke specialist, and a stroke specialist review done in 21 days, then aspirin and clopidogrel. If it is done in more than 21 days, only clopidogrel, along with PPI and statins.
Very good. And what about the referral? When do you refer to the stroke specialist? If the patient comes immediately, then within 24 hours. If the patient comes more than 7 days, then referral within the next 7 days.
Next 7 days. Yes.
Okay. Now we have finished the 3 areas. So we have discussed this whole neurocritical care aspect, stroke aspect in the form of TIA versus stroke versus traumatic head injury. In that, we have completed the TIA part. Shall I move on to the stroke part? You want a little bit of 5 minutes or 6 minutes break? Or shall I move on directly? Go ahead. You tell me how you want. Yeah, go ahead. You tell me how you want it. We will proceed accordingly. Shall I go ahead?
Go ahead, sir.
Yes, sir.
Come on, people talk. Is it my audio? No, I'm not. We go ahead.
Yes, sir.
Okay, much better, people. Much better. So now we defined the stroke versus TIA. So we have defined the TIA. Now we proceed with the stroke, people. Now we proceed with the stroke. Same patient present with the unilateral weakness and then this clinical syndrome features, all the clinical features we expect to see in the TIA, unilateral weakness or sensory loss or aphasia or ataxia or visual impairment, or maybe the patient is having a headache or maybe the dizziness, sudden loss of balance, and all those features the patient is coming to you, and all those features the patient is coming to you, and then the symptom is lasting for more than 24 hours, then we used to call that as a stroke. So when the patient is coming to you with the stroke, you first need to rule out whether it is a what type of stroke. We have a ischemic stroke as well as the hemorrhagic stroke. Hemorrhagic stroke, we discussed that in the head injury, traumatic head injury area. In the stroke area, we discuss mostly about the ischemic stroke. So when patient comes with the acute onset of focal neurological deficit, you are suspecting it is a vascular event because stroke occurs due to the vascular event. Yes or no? Any clot, it travels to the brain, it can cause the stroke. So most probably it is due to the vascular event. So you suspect a patient with the focal neurological deficit, and you are suspecting it is due to the vascular. You are suspecting it is due to the vascular. The first thing you will do it on this patient is the NCCT head. What is the first thing you will do it on this patient? NCCT head. Okay. In that NCCT head, what are you looking for? What do you usually look for in the NCCT head? You will look for either an infarction or the hemorrhage. You will look for either an infarction or the hemorrhage. There is a 2 probability you will get it in terms of positive findings. Or you may get a normal NCCT. Or you may get a normal NCCT. The screen is visible to you guys or not?
Yes. Yes.
Okay.
Yes, sir.
So you order him, you are suspecting this patient is having a stroke. So you are sending him to take a NCCT. And when you are taking an NCCT, you are possibly expecting 2 things, either an infarction or hemorrhage, or maybe the normal NCCT. If there is an infarction or hemorrhage, then no need of a further imaging because we identified it. No need further imaging because we identified the problem. In case, if the patient is having a symptoms and CT is normal, what does this patient needs?
Yeah, ma'am.
Go ahead, people. This patient may need MRI, but we aren't sure whether this patient is a MRI compatible or not. Consider this patient is having a steel rod inside, and you are trying to do the MRI with that patient. What will happen? Nowadays, they are putting a platinum and other metals, which is MRI compatible. But what in case if they are not having that material, and you are having these things? The patient will become MRI incompatible, right? Yes or no?
Yes.
So in those cases, you have to assess whether the patient is MRI compatible or not. MRI compatible or not. Okay, consider this patient is MRI compatible. Then we go for the MRI DWI. MRI DWI with the ADC mapping, but ADC mapping is not necessary. Okay, ADC is nothing, just the apparent diffusion coefficient. Okay, and we go for the MRI DWI. And in the MRI DWI, we will discuss the size of the MRI. Sorry, size of the infarct. If the infarct is more than 100 cc, you don't need any imaging. No need of further imaging. In case if the MRI is, if the infarct is less than 100 cc, that means it is suspectable. So we don't know whether it is a acute or it is nothing, just a normal blood flow. So you have to do the MR perfusion study. Okay, cerebral blood flow mapping you have to do. MR perfusion study. And then you, in the MR perfusion study, you can clearly understand. In case if the patient is not MRI compatible, you directly go for the MR perfusion study. Okay, MR not incompatible, you go for the CT perfusion study. CT perfusion study, very sorry. Okay, so this is the imaging guidelines, investigation guidelines for the imaging. So when the patient is coming to you with the acute onset of focal neurological deficit, what is the first thing? You think whether it is due to the vascular or it is due to the functional. When you're thinking it is due to the vascular, what is the first thing you do? You do the NCCT head. In the NCCT head, if it is you are going to look for two things. What are the two things you look for, people? Go ahead, answer more. Okay, you finished writing? When you finish writing, say yes, we proceed. No problem.
We see for the infraction or whether it is hemorrhage or normal.
Yeah, very good. Consider this patient is having a normal CT. Normal CT is there, and consider like this patient is okay. And in that case, we can leave. But the patient is not okay and CT is normal. You have to order a MRI. You have to check whether the patient is MRI compatible or not through the history. When you are taking out the history and you found out whether the patient is MRI compatible, the next test you're going to order is MRI DWI.
Right.
Okay. And MRI DWI shows the infarction of more than 100 cc, then we can say no further imaging. Okay. But in the case of NCCT head, you find out a infarction, then it is a ischemic stroke. You find a hemorrhage, then it is a hemorrhagic stroke. Okay. You find an infarction, then it is a ischemic stroke. And then you find a hemorrhage, you will find a hemorrhagic stroke. Okay, sir, I find other things than the hemorrhage. What are the CT findings you may expect in the case of your neurological deficit? When the patient is coming to the acute neurological deficit, what are the CT changes that you may expect? Okay, this is not for the stroke, this is the general one. So patient is coming with the focal neurological deficit. Focal neurological deficit, FND. The patient is coming with the focal neurological deficit. CT you ordered. What are the things you may expect on the CT? First one, it could be the ischemic lesion, or it could be the hemorrhagic lesion, or it could be the non-hemorrhagic lesion. Okay, three types of lesions you can expect. What is this? Ischemic, hemorrhagic, and non-hemorrhagic. You can ask me, why not non-ischemic lesions? Non-ischemic lesions are hemorrhagic lesions. Okay. Non-ischemic lesions are hemorrhagic lesions and non-hemorrhagic lesions. Okay. So we can proceed with that. So ischemic lesions means we can find a variety of stroke features. Okay. Common important features you will see on the report. What are the things? Hyperdense artery. Hyperdense artery you can see. Hyperdense artery you can see. Or you can see some typical words. What are the other typical words? Apart from the hyperdense artery, what are the other typical words you may see? Loss of cortical gray-white differentiation you will see. Loss of cortical gray-white differentiation. Classically, you will see in most of the reports. Gray-white differentiation. Okay. Or you may see this insular ribbon sign and this panda sign and then this river sign and all the named signs you may see. mainly you will see this kind of words. Okay. If it is a hemorrhagic thing, you can clearly see the hemorrhage. You can clearly say the hemorrhage with the hypodense or hyperdense lesion, concave or convex lesion. Based on that, you can classify EDH, SDH, SAH, ICH, and all. Okay. What are the non-hemorrhagic things you may expect? The non-hemorrhagic things you may expect could be most probably tumor or abscess. Tumor or brain abscess you may expect to cause this kind of symptoms to the patient. Okay, these are the normal focal neurological deficit CT findings you may expect to see in the patient. It could be the ischemic, or it could be the hemorrhagic, or it could be the non-hemorrhagic lesion. So speaking about the ischemic stroke, let's consider about the ischemic stroke. Okay, shall we move on to the ischemic stroke? You have finished writing? You have finished writing? Once you finish,
Yes,
tell
sir.
me. Okay, so now let's come back to the patient details. Okay, the patient is coming to you with the unilateral weakness, sensory loss, aphasia, atraxia, visual problem, or maybe the other focal neurological deficit. The patient comes to you, you did your initial preliminary workups, and then you find you suspect stroke, you send him for NCCT, and NCCT showed ischemia clearly. Okay, NCCT showed a ischemia clearly. Now, what could be the things? We are going for the ischemic stroke. Ischemic stroke, based on the artery, it can be classified into 3 types. Okay, ischemic stroke based on the circulation, it can be classified into 3 types. Okay, one is an anterior circulation infarct, anterior circulation infarct, posterior circulation infarct, anterior circulation, posterior circulation, and lacunar infarct. Anterior circulation infarct, posterior circulation infarct, and lacunar infarct. Okay. So what is this anterior circulation, posterior circulation, and lacunar? So we don't really understand this. Okay. So you know the image of the circle of Willis? You guys remember the image of circle of Willis, or do you want me to just revise it once? No problem. I can do it.
Revise it.
Please revise it.
Okay, revise it. Okay, no problem. So here you see the circle of Willis. Circle of Willis receives the brain receives the major arterial supply from 2 arteries. What are they? Basilar artery and carotid artery, if I'm right. Yes or no? So consider there are 2 vertebral arteries, and these 2 vertebral arteries will combinedly to form a basilar artery. These 2 vertebral artery combine to form a basilar artery. Okay, and this basilar artery will go upwards. Where does this vertebral artery comes from? Where does this vertebral artery comes from? Faster, faster. Come in. You have to say it faster. Vertebral artery. First part of the subclavian artery in the upwards. Okay. Subclavian artery, where does it comes from?
Arc of a
Arch of aorta on one side. On another side, brachiocephalic trunk.
Brachiocephalic.
Okay. So they comes from the subclavian artery. The first part of subclavian artery gives rise to vertebral artery. Vertebral artery on both sides combines to form the basilar artery. And this basilar artery gives rise to multiple branches. The first branch could be the anterior inferior cerebellar artery. Anterior inferior cerebellar artery. Cerebellar artery, and then you have a numerous pontine and numerous pontine branches, and then one major superior branch called the superior cerebellar artery. So there are multiple arteries which goes from there. What I am going is like a very major arteries. Okay. So superior cerebellar artery, anterior inferior cerebellar artery, basilar artery, and pontine artery are the branches comes from the basilar artery. And then when goes upward, they form this posterior cerebral artery. They form this posterior cerebral artery. Posterior cerebral artery. And when this posterior cerebral artery, it gives rise to a small communicating branch. This posterior cerebral artery is giving rise to a small communicating branch, which is a posterior communicating artery. And this small posterior communicating artery will go and attaches or communicate with the big artery. What is the big artery? Internal carotid artery or carotid artery. Okay, internal carotid artery. Sorry for the poor diagram, people. Adjust it kindly. I'm very bad in diagrams. But at least you guys are understanding or not? The posterior communicating artery is combining with the posterior communicating
Internal
artery,
carotid.
the internal carotid artery. And internal carotid artery, before receives the input from the posterior communicating artery, it gives off the branch called as middle cerebral artery. Middle cerebral artery. Middle cerebral artery. And then it gives rise to two anterior communicating branch. And then it gives rise to two anterior communicating branch. And this two anterior communicating branch will form combinedly and forms the anterior cerebral artery. Anterior cerebral artery. Now you got the whole circle of Willis, people. So you have the basilar artery. Basilar artery gives rise to posterior cerebral artery and then posterior communicating branch. And this posterior communicating branch will communicate with the internal carotid artery. Before receiving input from there, it gives rise to middle cerebral artery. And then you see the anterior communicating branch. And then the anterior communicating branch combines to form an anterior cerebral artery. Okay, so you know anterior cerebral artery, middle cerebral artery, posterior cerebral artery, and then superior cerebellar artery, and then anterior inferior cerebellar artery. Okay, anterior inferior cerebellar artery, just above them, you will have a posterior inferior cerebellar artery, which should be running on the posterior course. So I will mention it as a dot. Okay, posterior inferior cerebellar artery. So you got to know all of them. This anterior and middle cerebral artery and posterior cerebral artery will supply your cerebrum and then all the internal areas of your brain. Okay, based upon the location of the infarct or the arterial infarct, you will have the variety of clinical symptoms. You will have the variety of clinical symptoms based on the location of the artery. Okay, for example, anterior cerebral artery. So I will list out here all the symptoms based on the arterial thrombus. Consider anterior cerebral artery, ACA. If the ACA is lost, what could be the clinical feature? Contralateral hemiparesis and sensory loss. But where you will see, here what the difference comes, you will see it in the lower extremities over upper extremities. Okay. You will see it in the lower extremities over upper extremities. And apart from that, you will see there is a urinary incontinence. You will see there is a urinary incontinence. And you will see there is a personality defect. Personality defect. Why? Because anterior circulation mostly communicates where exactly? Frontal lobe. So frontal lobe is responsible for your decision-making capacity, cognition, and then it is also responsible for the motor function because you have a premotor cortex and a primitive motor cortex there. So you will have a personality defect, you will have a urinary incontinence, and you will have a contralateral hemiparesis and sensory loss, but typically seen in where? Upper extremities or lower extremities?
Lower extremities.
Lower extremities, typically you will see this ACA finding. Okay, and similarly, now we are talking about the MCA. So can somebody tell me what are the clinical features patient comes with if the ACA artery is involved?
Contralateral hemiparesis with sensory loss.
Hmm.
More in lower extremities than upper extremities.
Very
May
good.
present with urinary incontinence and
Very good.
personality defect.
Very good, people. And then now we are going for the MCA. Now we are going for the MCA. Speaking about this MCA, you will see this contralateral hemiparesis and the sensory loss. You will see the contralateral hemiparesis and the sensory loss, but most commonly seen in upper extremities over lower extremities. UE over LE. Okay, you will see contralateral hemiparesis and sensory loss in the upper extremities and the face over the lower extremities. Okay, apart from that, you may see contralateral homonymous hemianopia, contralateral homonymous hemianopia, and apart from that, you will see the aphasia. It could be the Broca's or Wernicke's, anything, but it is a aphasia. And you will also see the hemi-neglect. You will also see the hemi-neglect. And you will also see amaurosis fugax. Amaurosis fugax. These are the features of your middle cerebral artery, people. So tell me, what are the middle cerebral artery?
What is hemi-neglect?
You will neglect one portion of the body exist in your body. You will do all the functions with the one side.
Okay.
Okay. So can somebody say the features of the MCA?
Contralateral hemiparesis, involvement more in upper extremities than lower extremities, and
Yes, very good.
associated with contralateral homonymous hemianopia,
Very good.
and maybe aphasia, maybe Broca or Wernicke's, and
Yes,
hemi-neglect,
very good.
amaurosis fugax.
Okay. Okay, these are the things. Okay, then we go for the posterior cerebral artery. So posterior cerebral artery, if you are going, you will see the visual agnosia. You will see the visual agnosia, and you will see the contralateral homonymous hemianopia. Contralateral homonymous hemianopia, but this time with the macular sparing. With macular sparing. Very important MCQ in terms of the posterior circulation, whatever the exams you have been preparing for it. Okay. That is the difference between your middle cerebral artery and posterior cerebral artery involvement.
So what is visual agnosia?
Visual agnosia is just the finding inability to fit in the objects. For example, consider you see the square and a circle. The child will try to put the circle in the square, right? Circle has to go inside the circle and the square has to go inside the square. So this impairment in the three-dimensional view or of your vision. That is a visual agnosia. Okay. Done?
Yes.
Okay. Next, we go for this anterior inferior cerebellar artery and posterior inferior cerebellar artery. AICLA, anterior inferior cerebellar artery. Okay, if you don't remember this AICLA, write it in a full way. Don't confuse later. Okay. I write it as AICLA, but if you are confused, write it anterior inferior cerebellar artery. Okay.
Yes. Yes.
Okay. You will see the ipsilateral facial paralysis and deafness. Ipsilateral facial paralysis and deafness and symptoms of Wallenberg syndrome. Symptoms of Wallenberg syndrome. I will tell you what is a Wallenberg syndrome. Okay. Now, this is the anterior inferior cerebellar artery. While posterior inferior cerebellar artery, you will have Wallenberg syndrome. When they ask you Wallenberg syndrome, next thing you have to see is whether there is an additional feature of ipsilateral facial paralysis or deafness there or not. If not, then blindly choose the posterior inferior cerebellar artery. Okay. Wallenberg syndrome is associated with ipsilateral ataxia, contralateral sensory loss, and nystagmus. Ipsilateral ataxia, contralateral sensory loss, and nystagmus are the three features of your Wallenberg syndrome and the features associated with the Wallenberg syndrome. When you see this thing, you have to immediately go for the posterior inferior cerebellar artery after ruling out ipsilateral facial paralysis and deafness. Okay, after ruling out your ipsilateral facial paralysis and
Facial
deafness.
paralysis and deafness.
Very good. So we have almost seen all the things. While you have basilar artery, you will result in the locked-in syndrome. Patient feel like they have been locked and they couldn't move any of this limbs. That is due to the basilar artery, but that is not necessary. But these are the important ones. So if you understand the circle of Willis and if you understand this arterial clinical functions, it is very easy to identify when the patient walks in, you can able to say this is a ACA involvement, PCA involvement or MCA involvement by seeing the patient itself. Okay, before ordering the CT scan, you can directly say this might be the ACA involvement, check once with the NCCT. It might be the PCA involvement, check once with the NCCT, or we can say CT angiography, or we can say CBF analysis, or you can do anything, you can easily find it out. Okay. Now, or if you want to know the features based on the location of the brain, like I want to know the location of the brain, sir, I recommend you, there is a image in the macleoid. Okay, if you want, I will share it later. There is an image in the macleoid. They had wonderfully portrayed with the frontal lobe lesion, temporal lobe lesion, and this occipital lobe lesion, and then parietal lobe lesion, dominant versus non-dominant. In the clinical examination criteria, there is this image which is very much, that is my favorite image. In case you want, you find a better image, you can also the same. No problem. So this is a stroke by the vascular anatomy. So can somebody explain me the circle of Willis? And one person
Excuse me,
explain
sir.
me the circle of
Sir,
Willis.
what was the feature in basilar artery?
Basilar artery.
Locked, what you have said, sir? Locked,
Yes.
and I got quite confused
Locked-in
here.
syndrome. Locked-in
Pardon, sir?
syndrome. Locked-in syndrome. Yes.
Okay. Okay, thanks.
Okay. One person explain me the circle of Willis and another person explain me the features of each artery lesion. That is, patient will feel like they are locked. They are sitting and they are aware like what is happening around them, but they cannot move any of them. They cannot speak. They cannot move. They cannot but they are awake. They understand everything, but they cannot respond. That is called as locked-in syndrome because basilar artery is a major artery. No. It carries your anterior inferior cerebellar, posterior inferior cerebellar, posterior cerebral, and a part of the posterior communicating artery. All of this whole part is damaged. No? That's why.
Yes.
Okay. Why not other
Okay,
people? Yes, circle of Willis, explain.
Circle of
So
Willis.
everybody can understand.
Uh, Basilar artery is a branch of vertebral artery from both sides, and there are branches. The most inferior branch, anterior inferior cerebellar artery. Then a small branch, pontine artery. Then above that, superior cerebellar artery, and then posterior cerebral artery. And posterior cerebral artery gives branches on both sides. And above that, it communicates with internal carotid artery. And there is another branch, posterior communicating artery there. And in internal carotid artery, before entering, there is branch middle cerebral artery on the right side, and on left side, interior communicating branch. It gives anterior
Yes.
communicating branch, and
They come-
anterior
and-
cerebral artery.
Okay, I want the other person, any other person, to explain me each artery. What are the clinical symptoms you will see? Anybody, people, willing? Or you want me to call out the names? I feel a little awkward to call out the names. We are not child, we are adults, right? So come yourself and talk, because the more you talk, the more you learn, as I always believe. Yeah, go ahead, somebody.
It's ACA, contralateral
Yeah.
hemiparesis and sensory loss.
Yes,
More in
very good. Yeah, go ahead.
in ACA, there is also symptoms of urinary incontinence and personality defect.
Very good.
If involved in MCA, there is
Yes.
a contralateral hemiparesis and sensory loss, more in upper eye than the
Lower extremity.
lower
Very good.
lower extremities.
Yes.
And there is also contralateral hemianopia, aphasia.
Okay, very good.
Then, if
And
involving
hemianopia.
in posterior
Hemianopia.
communicating artery, there is a visual agnosia.
Yeah. Go ahead. Go. Contralateral.
Homonymous anopia with macular sparing.
Macular sparing. With the macular sparing. Very good. Okay, go ahead. Someone.
Anterior inferior cerebellar artery. Ipsilateral facial paralysis with deafness and symptoms of Wallenberg syndrome. And if there
What are
is
the
only
symptoms of
what
What are the
Wallenberg syndrome, it is posterior inferior cerebellar artery. There is only Wallenberg syndrome, and it is associated with ipsilateral ataxia, contralateral sensory loss, nystagmus may be there.
Very
And
good.
in basilar artery, locked in syndrome.
Very good, people. So you guys have understood most of them. So we know that the investigation of choice, you may see that the investigation of choice is this. Okay. And apart from that, stroke screening, nowadays we are following this fast screening, people, for the stroke. Ischemic stroke especially. Screening is a fast screening. FAST. What are the component of FAST? Face, arm, speech, and time. Okay, what is that? Face, arm, speech, time. This is a fast screening. Okay, so the positives and the negatives are there for the fast screening. So if the stroke is most likely, if there is any positive is there. Okay, if you are giving a fast screening, I would rather write positives and negatives. We'll go in this way: positive, negative. So the positives are asymmetric weakness on a body. It could be anywhere from asymmetric weakness on the body. It could be anywhere from the face, arm, or leg. If it is there, you have to give +1. Okay. And then if there is a speech disturbance, you go for +1. Okay, speech disturbance, you go for +1. Visual field defect, you go for +1. Visual field defect, you go for +1. Okay, so you have a 3 +1s here. For a asymmetric weakness, you give 1 mark. Speech disturbance, you give 1 mark. Visual field defect, 1 mark. Okay, if the patient is having a loss of conscious or syncope, the patient has giddiness, then you give a -1. Okay, -1. And if the patient is having a seizure, then it is another -1. Seizure, it is another -1. So you have a 2 on the minus area and 1. Stroke is likely if it is more than 0. Stroke is likely if more than 0. You got that, people? Very good. So now, let me move on to this management protocol first. So speaking about the stroke management protocol, so you saw this person who is coming into here and you are thinking
Sir,
about like...
Could you
patient is
explain
having-
1 second regarding fast screening? FAST,
You
face,
check-
arm,
you assess-
speech, and time.
Yes, face, arm, speech, and time. So it's just you are assessing how long it is having, how long the speech is impaired, how long the symmetrical weakness in the face or arm is impaired, and this is what the fastest screening is. In that, if you see the weakness on the face or arm or leg, you will put 1 point. You will see any speech disturbance, you will put 1 point. Visual field, you will put 1 point. If you see the patient is having a syncope or loss of consciousness, you will put a -1 point and seizure -1 point. Why they are -1 point? Because it is ruling out the vascular causes. If anything goes on the +1, then the patient is highly having a stroke. Okay, you just ask the patient with a series of questions and you see the signs and symptoms, you make this point. Okay, consider I am a stroke patient, I am coming to you with the unilateral weakness on my arm and the leg, and then I am having this angle of deviation of mouth with the slurring of speech, and I'm having a contralateral homonymous hemiparesis. I'm having a asymmetrical weakness. I'm having a +3 because face also I'm having, arm also I'm having, leg also I'm having. So +1 for each, +3. Then speech disturbance, 1 because I'm having a slurring of speech. Then I'm having a monoocular blindness, which is amaurosis fugax, that is another 1. So I'm having a 5 points. So technically I'm having a stroke. Consider I'm having a speech disturbance and I'm having a seizure. +1 and -1, it is 0.
Yeah.
Yes or no? Because the vascular cause has been ruled out. So it is a fast screening is used for the assessment whether the stroke is there or not. In a quick way, like 3 to 5 minutes. 1, 1, 1. Okay, 1, 1. Okay, he's having a stroke, put him on the NCCT. We will directly put him on NCCT? No, we are sitting in the ER row. We will check the blood glucose, we will check the hydration status, we will check the vitals, we will exclude the hemorrhage. Then we will do the NCCT. If there is no exclusion of hemorrhage also, then we do the NCCT to rule out a hemorrhage. Then we start him on the initiation of treatment. What could be the initiation of treatment? Aspirin, 300 milligrams stat. If the cholesterol level is more than 3.5, then you have to start him on with the statins also. Okay, when do you thrombolize people? I'm really having a little bit of things here. When do you thrombolize this patient?
Is in
Before
ischemic
4.5
stroke.
hours.
Ischemic stroke is there, but when do you thrombolize the patient?
Oh. I think we should assess the size of infraction. I think if it is more than 100 cc, then. All right, sir.
Okay, I tell you, interesting
Duration.
story. I tell you one interesting story. Okay. It has been around like how long? I still don't remember. Around 3 to 5 years ago. 3 to 5 years ago, I guess. Okay. So there was a patient who is a 60-year-old male who is presenting to us with the unilateral weakness, and he is having an angle of deviation of mouth, and we are suspecting the CT, and we ordered a NCCT. Okay. The NCCT showed there is a mass and large infarction noted on the parietal lobe with the deviation of the central axis along with the hemorrhagic transformation. Okay, this was supposed to be in the this is a vague report because I couldn't able to remember what exactly he was saying. Okay, that time the guy was calling me and informing about the report. That time he skipped the part. What part he skipped? He skipped the hemorrhagic transformation part. He told me large infarct noted on the parietal lobe, sir. That's it, he told me. But there was a large infarct noted on the parietal lobe along with the hemorrhagic transformation. What is the protocol? Now it is a ischemic stroke or hemorrhagic stroke?
Hemorrhagic stroke.
Hemorrhagic stroke, right? But the guy who missed the hemorrhagic part, what I received?
Ischemic.
What I can assume?
Ischemic, but actually it was hemorrhagic.
Actually, it was hemorrhagic stroke, but he read only half of the report without saying me the another half. Okay, it was around like 5 years ago back. Okay, then what I went accidentally by the God's grace, or I maybe something I was fine. I was accidentally walking into the room. That time I was around the hospital, and I told I will come and write the orders. When I was going and reading the report, it was clearly written as hemorrhagic transformation. Can I scold that guy or not? You tell me one thing, can I scold that guy or not? I should have to scold that guy, no?
That guy might have learned a lesson on that day.
But I didn't scold that guy because he's an intern. So I told him, no problem. But thank God I seen that. Never make the mistake again in your whole life. And then I started him on aspirin 325 milligram. And I started him on these things. Okay, anyway, we go for the management
So
protocol for the...
Can we give aspirin in hemorrhagic stroke?
No, man. How can you give? Patient dies.
So
In hemorrhagic stroke, patient is bleeding.
Yes, sir. So in that case, how aspirin can be given? In that case,
We can't.
that you have
We can't.
Yeah.
We can't give the aspirin. That is a hemorrhagic stroke. The protocol is entirely different. That we are going to discuss now. How the protocols of the hemorrhagic stroke and what are the protocols of the ischemic stroke. Okay, if it is a hemorrhagic stroke or hemorrhagic transformation, first clear off the hemorrhage first. And then proceed with the other stuffs. Okay, this is what the actual thing is. But anyways, we move on to this management protocol for the ischemic stroke. So speaking about the management protocol for the ischemic stroke could be due to the thrombus or embolus, mostly embolus. Okay.
If the patient is suffering from both its hemorrhagic and ischemic stroke, hemorrhagic and STMI, can we give aspirin?
No, we can't give STEMI.
For the management of STMI, what can I give prefer?
Wow. Come on, man, relax. What you are saying, I couldn't able to clear it up.
For
Speak
STMI,
slowly. Okay.
STMI and the patient suffering from both ST segment elevation of MI and hemorrhagic stroke, can we give aspirin or not?
How can you are talking about the patient is coming with a STEMI?
Yes.
So you have a clot on one side and on another side it is bleeding.
Yes. For that situation, what can I prefer for the?
Okay, no problem. Control the bleed first. Because brain is important. If the patient heart stops, no problem. We can resume the arrest. In that situation, 90% patient dies.
And
Yes
can
or
we
no?
give one
In that situation, 90% patient dies. First, control the brain, because brain is more important than the heart. Prioritize what you want and then work on that area. You got that? Because what you are saying is a not normal situation. It is a very, very abnormal situation. In that situation, you have to sit on the desk, you have to think, you have to save the brain or you have to save the heart. If you save the heart and the patient is brain dead, it is no use, right? Am I right or wrong?
Yes.
Yes, yes.
So what you are studying and what you are expected to see on the ER is entirely different. Okay. So if the patient is coming to you with this kind of situation, it is a very abnormal situation. Mostly patient
Up to
won't
how much
survive
dose I
coming to
can
the
give
hospital.
morphine for the pain management in the
Okay,
emergency stroke with
give.
STM?
Okay, what you will
Up
do
to
as
how
a
much
doctor
dose?
then? What you will do as a doctor in the ER? Go ahead.
Yes, yes. I will give morphine
Okay.
for the management of the pain, for the chest pain, and for because morphine caused respiratory depression, and there is a hemorrhagic stroke. It also causes respiratory depression. So I can give morphine or not?
Okay. What I'm asking is what you will give. You give morphine.
Yeah.
Okay, then
Yes, yes.
explain me
Can
the
I?
scenario, how the patient comes to you, how you are going to use it. Then I can solve
One-
your doubts.
About 65 years old male presented to ER with a
Okay,
present
very
complaint
good.
of chest pain.
Let me write it down. Let me put it to your words. 65-year-old male.
Presented with chest pain,
Okay, chest pain.
with ipsilateral weakness.
Chest
One
pain
side.
and ipsilateral weakness. Okay.
Yeah. And then one side people slightly reactive.
Okay.
And the patient complains with the pain and vomiting.
Okay.
And there the patient has the tachypnea.
Okay.
How I will manage this case?
How
And
long?
in the ECG there is a ST segment elevation.
Okay, boss. Okay. Relax. 65-year-old male, chest pain, ipsilateral weakness, slightly reactive, pain, vomiting, tachypnea. I will
Yes.
directly order NCCT.
Yes, and in NCCT there is a hemorrhagic stroke. Then
Hemorrhagic stroke. It is due to what?
due to hypertensive.
Hypertension causes a hemorrhagic stroke. Bleeding powerful enough. The BP is powerful enough to rupture the brain vessels and not powerful enough to cause the heart vessels to rupture.
One case I have seen, so that's why I'm asking that.
No, I'm saying we can argue in 1,000 ways, but in this situation, check because you are the ER doctor. Okay, we can check which one is actual findings and what are the actual findings, and you can take a decision based on the timings, whether to save your heart first or the brain next. You got that, boss?
Okay.
You know the
sir.
protocol for STEMI and you know the protocol for the stroke, because which I am going to teach now. So you can take the call based on the situation rather than I have to do this first, I have to do that first. Can I give this? Can I give that? Instead of that, take a decision because you are a doctor and you make the decision call. Yes?
Okay.
Okay, very good. So let's move on to the management protocol for the ischemic stroke. Everybody? Shall we move on to the management protocol for the ischemic stroke?
Yes.
Okay.
Yes.
No problem. So the management protocol for the ischemic stroke, the first one is a thrombolytic therapy. When we will give the thrombolytic therapy should be given within the first 4.5 hours. Within first 4.5 hours. Okay. What could be the thrombolytic therapy? Optimal thrombolytic therapy for the stroke is the altiplase. We used to do it with the altiplase. Okay. Which is a 0.9 mg per kg per dose, or max 90 mg per dose over 60 minutes. Okay. Over 60 minutes with bolus of 10% on first 1 minute. On the minute 1, you have to give the 10% of the dose as a bolus, and the remaining 90% should be slowly transfused over for another 60 minutes. I can say 59 minutes. Okay. So this is a TPA, tissue plasminogen activator, which is a thrombolysis factor. So when we are giving a TPA, when you are thrombolizing the patient, the main thing you have to consider, because if these conditions are applied, then you cannot able to do the TPA. Okay, the first thing, the inclusion criteria and exclusion criteria. The inclusion criteria, it is always within the first 4.5 hours. If not, then it is not useful. Okay, if the patient is coming to you with the 3 to 4.5 hours, then you can, that is the optimal time for the thrombolysis. Okay, well, the exclusion criteria, when we will not do the thrombolysis. Exclusion criteria, when we talk about what are, when we will not do it. I'm so sorry, I'm taking plenty of your time, I guess. Anyway, we will finish up the management and then we will stop it. Okay. So whenever the patient is taking an anticoagulant, whenever the patient is taking an anticoagulant with a PT of more than 15 seconds and INR of more than 1.7. PT of more than 15 seconds and INR of more than 1.7. So the current use of anticoagulants, or the patient is having a PT of more than 15 and INR of 1.2. Okay. Any stroke or head injury in the past 3 months. Any stroke or head injury in past 3 months. In past 3 months. Okay. Any major surgery within past 14 days. Within past 14 days. Okay. Any major surgery within past 14 days. And if SBP is more than 185 mm of Hg, if SBP is more than 185 mm of Hg and DBP is more than 110 mm of Hg. DBP is more than 110 mm of Hg. Apart from that, the patient is having a recent MI, any GI bleed or you may have the urinary bleed in preceding 21 days. That is before 21 days, if they have any GI bleed or a urinary bleed, it is the exclusion criteria. But the major one is, we always ask whether you have underwent any surgery, or you have any head injury, or you have any anticoagulant. Are you on any anticoagulant? So that is a thrombolytic therapy, people. So when the thrombolytic therapy, most commonly used thrombolysis agent is a altiplase, which is a 0.9 mg per kg per dose, or 90 mg as a maximum over 60 minutes, with the bolus of 10% should be given in the first minute. Okay, we saw the exclusion criteria. Then we have the neuroprotectives. The second treatment is the neuroprotectives. We have a lot of neuroprotectives on the markets, so you can give them anyone. Okay, then you have to give an antithrombotic therapy. Antithrombotic therapy. Thrombotic therapy followed by the seizure management. Seizure management followed by the glycemic control. Glycemic control followed by the pyrexia management. Pyrexia management. So speaking about this, these are the important ones. So you have found this, the management protocol for the ischemic stroke paper. So shall we move on to the management protocol for the ischemic stroke? So whenever you walk into the ICU as a intern or as a GP, you walk into any ICU when the patient is on the these things, what do we call it? When the patient is on the list of medication, you review the patient chart with the drug charts. On the drug chart, what are the common things you will find? Clopidogrel, aspirin, and paracetamol, levetiracetam. We used to give a levetiracetam 4.5 grams as a stat and 1.5 TID. Okay, and then followed by you have a neuroprotective. We used to have this tablet Strosit. I don't know in Nepal also you have a Strosit or not. We used to give a Strosit, a neuroprotective. In Nepal you have a Strosit tablet.
Citicoline.
Which one? Citicoline. Yeah, citicoline is a drug name. You have a citicoline in the form of Strosit or other one?
It is brand name.
Okay. Citicoline is a drug name, actually. Okay, no problem. You have a neuroprotective, you have an aspirin, you have a clopidogrel, you have a levetiracetam, and if the patient, you have a paracetamol. And if the patient is diabetic, we call whom the endocrinologist or the internal medicine guy to manage the glycemia, hyperglycemia. Okay. So the stroke with the epilepsy is a dangerous complication. Whenever the patient exits with the stroke and the stroke is not resolved and the patient progresses to seizure, then it is a very dangerous complications. Okay. And do you do the surgery?
Sir, what is the basis of use of levetiracetam?
Levetiracetam is an anti-epileptic drug.
Okay.
It is an anti-epileptic drug to control your epilepsy. And speaking about the levetiracetam and lamotrigine is one of the common broad spectrum anti-epileptic, which means you can give it to any type of seizure. Okay.
Yes.
So these are the things you may expect to see on the drug chart of the patient with the ischemic stroke. What are they? Can somebody explain once?
Sir, excuse me, sir. When should we use plasminogen, tissue plasminogen activator?
I told you within 3 to 4.5 hours.
Within
3 to 4.5 hours of onset of the symptoms. I told you.
2%. So, which suite do we prefer? TPA or Altiplase? Altiplase?
Altiplase is kind of TPA.
Yeah, okay. Okay,
Okay.
thanks.
Anything else?
No, sir.
Okay. So can somebody explain the immediate management of the ischemic stroke, acute phase managements?
In ischemic, yes.
Yes, go
Ischemic
ahead.
stroke, aspirin 300 mg and statins if there is hypertriglyceridemia, and thrombolysis if comes within 3 to 4.5 hours, and thrombolysis, as a thrombolysis we use Altiplase 0.9 mg per kg per dose. Maximum 90 mg per dose over 60 minutes. and given bolus as bolus in first minute, 10% on first minute.
Yes. Of the whole dose, you have to
And,
give 10% on the first minute. Then remaining, you have to
yes.
do the slow infusion for over 59 minutes. Very good.
Yes.
Go ahead.
Then neuroprotective, and neuroprotective like citicoline, and seizure control. For seizure control, we give levos, tricetam, and next glycemic control and pyrexia management.
Okay, very good, people. Now I'm coming to the clinical considerations. So now I'm having the patient, okay? Now I'm having the patient with the acute stroke, ischemic stroke, especially on the MCA circulation. I have been sorting out all the things and I have initiated all the treatment. Now the patient, the nurse is asking, sir, shall we put a Foley's on this patient? Can we put or not? The nurse is coming to you and asking, you are the ER physician, you have come to, you received the patient and you diagnosed him with, after the CT findings, you diagnosed him with acute ischemic stroke and you initiated him with the thrombolysis and you started him on aspirin and all the neuroprotective seizure management, glycemic control, all the, whatever the charts we have done, all the things you have written and they have executed the orders. Now the nurse is asking you from the ER bedside, sir, can I put a Foley's on this patient or not? And your answer would be
Yes.
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 You can say like a yes to the patient or not.
No.
I receive one answer. Yes. Yes.
Yes. Yes.
Okay.
Since this
There is
is ischemic stroke, I
There is
don't
a-
think there will be contraindication for Foley's catheter.
there
in
is
this
a
case.
there is a problem here. There is a problem here. You have given a thrombolytic therapy. You have thinned the
Okay.
blood, and now you are putting a catheter. Accidentally, if the patient bleeds, what will happen?
Excessive bleeding.
Okay. Bleeding for urethra.
Yeah.
Maybe in urethral injury,
Yeah.
excessive hemorrhage can happen.
Yes. Yes or no?
Yes.
So now
Yes,
tell
yes.
me, now I told you what will be the basic complication you expect. Now tell me, can we do the Foley's for the patient or not?
I think Foley's catheter should be applied before starting the treatment, before giving the treatment.
Okay. What the situation I had given you was the patient was, you have started all the things and the nurse is asking from the bedside, can I do the Foley's or not?
Yes, I can.
After starting the treatment, I think we should not apply Foley's catheter.
How many are saying yes? How many are saying no?
Yes, I'm saying yes.
No.
Okay, I rather say here the both answers, but you can say yes, but not now. When? After 24 hours. Okay. So
Yes.
you can write it as a note in a patients with the TPA or aspirin, the Foley's catheter should be delayed until after 24 period of post thrombolysis. That is the exact point I'm trying to convey to you people. Okay, you can do the
Yes,
Foley's catheterization, but you have to delay it at least for 24 hours. Okay.
I need 2 minutes break.
Okay.
Sir, I need a break for 2 minutes.
No, I think we are going to finish it up.
Okay.
I think we are finishing up the whole things. No problem. So far, the management protocol of the ischemic stroke has been done. Okay, in the further classes, we discuss about the hemorrhagic stroke in the form of the acute brain injury or head injury. We will discuss all type of hemorrhages and their management protocols and in all. Okay.
Sir, I have
So-
one question, sir.
TIA versus head injury. We have done with the stroke and the TIA. Okay. And we have done with a little bit of, we touched a little bit of basics of the system. Okay. So we are wrapping up. Okay.
I have one question.
Yeah, no problem. You can ask. I will be available for next 10 minutes for the doubt clearing sessions. So you can ask me any questions in case you need it, or you can type me. I will see it and I will answer it if you want.
For the head injury management, the fluid of choice is what, sir?
Which one?
Fluid choice.
Fluid choice. Basically, we give a RL.
In a head injury, sir?
In a head injury, the fluid of choice is isotonic. Yeah, we can give oral, no problem. In a head injury, you don't want to give oral.
So we are practicing that we don't allow RL, we will give NS, sir. Why?
Okay, why? You are giving a NS, so you say me why?
No. Sir, to maintain the sort of osmolarity or osmotic. If I give DNS, it causes in head injury. We cannot give dextrose with normal saline. But how to control with why we are giving NS only?
See, the oral usage in the head injury is usually the controversy. Why? Because the oral is having a slightly low sodium. Yes or no?
Yeah.
So when we are giving a slightly, what you are trying to imply here, and I can get from your way of question the information is, because of the low sodium, it can proceed to the cerebral edema and it can proceed to the brain swelling and it can worsen the hemorrhagic area and worsen the ICP. If I'm right, you are proceeding with that thing. Based on your question, I can.
Yes,
based
sir,
on
but
your
why
question,
why cannot we give DNS, sir? Dextrose with normal saline.
D5NS with the head injury. You mean like why we cannot give or why we can give?
Why we can't give, sir? Because we are practicing that way. When the traumatic head injury patient presented with ER, we always prescribe NS only. Yeah,
You are avoiding the D5NS. You are avoiding the D5NS. Why you are asking? So I can say three things. Number one is any hypertonical solution. We have a very cautiously we have to use it. Okay, so that's why we have to the D5NS or the RL. They're all a little bit hypotonic. That's why we avoid it. Okay, but isotonic NS is a isotonic or 0.9% NS is a clear isotonic fluid. We use it for the head injury. But speaking about for the D5NS, let me answer your question for D5NS and then I'll okay. Speaking about the D5NS, I can able to say there are a variety of reasons why we are avoiding it. Number one, it can trigger hyperglycemia. Okay. Number one, it can trigger hyperglycemia, and when the hyperglycemia is already there, and it can able to create a coma, hyperglycemic coma. And in the patient with the head injury, keeping him consciousness by reducing the ICP is a real ideal task. Okay, so we avoid giving that, so it can avoid triggering the coma, number one. Okay, number two, because again, D5NS is also having this cerebral edema worsening condition. Okay, because when we give a D5NS, the fluid will become hypotonic. When the fluid will become a hypotonic, automatically fluid shift will occur. No, so blood-brain barrier will have issues. Okay, so worsening of the cerebral edema, and number two is the causes of the hyperglycemic coma. And you also see there is a patient who is coming with the trauma. He may have the hypovolemic shock, and the controlling the fluid management and simultaneously you are working on the brain is a real tough task. That's why we prefer mostly. I don't say like we should not give, we should not do this, we should not do that. We avoid, because consider in the position where you are in the very periphery, you don't have any other fluid except RL. And what you will do? You have to flush him to save him first, right? Yes or no? Cerebral edema, okay. The complication comes, we manage it. The complication comes or worsening of cerebral edema, then we do the the mannitol and the blah, 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 all the nonsenses. We do that later.
yes,
But first we
yes.
have to sort out the problem. So there is nothing like we should not give, we should give. It's like we avoid. If we have a NS, I will put a NS. For me, if I have a 0.9% NS, I put a isotonic fluid because isotonic is more safer on the side rather than the hypotonic fluids.
Sir,
Yes
you
or
have
no?
told there is, yes, sir. You have told there is a management of the epilepsy, anti-epileptic, you have to start, you have to maintain the glycemic control, glucose level.
Yes.
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 During that
Yes.
control of glucose level, you have which fluid we have to prefer. If there is
Sorry,
25% dextrose, or 5% dextrose or 10% dextrose, which dextrose we can give?
Means like you are asking me for the seizure.
Yes. No,
Yes.
sir. If the patient present with a trauma, you have told.
Hypoglycemia.
Yeah, hypoglycemic, sir. If the patient is hypoglycemic, then which fluid we can be preferred? 25%
The
dextrose can
patient
compensate.
the patient is hypoglycemic.
No, sir. The patient present with a traumatic history, and you have told that
History of
D5.
trauma or present trauma.
Yes, sir. And then D5, I have regularly
I am
monitor
asking history of trauma or active trauma.
history of trauma. No, acute trauma, sir.
Active trauma. The patient coming from after the RTA.
Yes, sir.
Okay, the patient comes actually from the RTA. So the primary focus is ABCDE only.
Now you have told, sir, that you have to maintain
got-
the glycemic glucose level in the blood, sir. You have told, and you have told to
First,
maintain
we
the
have to
glucose.
rule out whether
See-
it is a stroke or not. If the
See,
patient
first
comes
of all,
with RTA, first we have
in
to
order to
exclude
see
whether
the patient is having a, let me pick it up. See, first of all, when the patient is coming to you in the ER or in the, first the patient comes to ER in the case of the RTA. Okay. Whenever the patient comes to the ER, you should follow the trauma protocol rather than focusing on the neuro and trauma. What is the trauma protocol? Manage this ABCDE first. Because you don't even have a patient stability level to shift him to the NCCT to rule out a hemorrhage first. Am I right or wrong? Most people, based on your question, you guys are a little bit like misinterpreting. I'm not in a way of reprimanding. I'm saying like, you are a ER physician, patient comes to you with the traumatic history, focus on ABCDE first. On the C itself, we will start isotonic fluids. Am I right or wrong? Then we talk about the brain hemorrhage and all those other things. Yes, you have to finish up the circulating shock. You have to save the patient from the death first. That is what the emergency is slightly on the par, right? Am I right or wrong? If I'm right. Maybe you have a controversy, you can say me. Because there is a way of difference in thinking between a doctor and between a medical student. Medical student thinks everything, but doctor prioritize the patient first. Yes or no? So based on the doctor way of thinking, I rather go for the situation. So patient airway is stable, then breathing is stable, but his patient is in a hypovolemia or hypoglycemia. I have to treat that first. Stabilize him, then shift him to the neuro, NCCT, right? Am I right or wrong? So next question.
You are right.
Yes. Any other people? So I'm available for next 5 minutes for the doubt clearing. If you have any doubts, you can shoot me and you can tell me how was the class. You can send me a message or here, how you liked it, or you enjoyed it, or you don't like it. Anyway, shoot whatever you felt in your heart. Anything. I'm all ears for this.
yes, it was interesting.
Okay, very nice. Glad to hear. I hope you guys have a little bit like a clarity in the topics, maybe, or maybe I'm not teaching you the same points that you have studied in the books. Maybe I might have teach the same points, but I may explain you in the clinical progress.
It's awesome.
Hmm.
Nice one, sir.
Thank you so much, everybody. The pleasure is mine, and the day is yours. Okay, we wrap up. Maybe we on the another session we may see the management protocols for the traumatic head injury and all the things. We may have plenty of time to discuss. When we discuss the medicine, obviously it takes a long time. So we see we probably planned for 2 hours. It went for more than 2 hours. Anyway, it's
Sir,
fine.
excuse me, sir. Sir, I request you to explain regarding contralateral homonymous enopia with macular sparing in posterior cerebral artery infarct.
Okay, macula will be spared in that. Just a simple terms, no?
Yes, sir.
You know the
So,
contralateral homonymous hemianopia means what?
one-sided enopia.
Okay.
And contralateral to the infraction side. That means opposite to
See, it is a
infraction side.
hemianopia. Okay. Let's explain it with the Greek modality. Okay. It is a hemianopia. Right?
Yes.
If it is a hemianopia, that means on one side you will have a half, another side you will have a half, which is not working. So your eye field will be two. Okay, one is a temporal eye field, another one is you have a
Right.
two eye field. No, what are the two eye field you are having?
Temporal and frontal.
Temporal and nasal field. Your eye will have a two.
Nasal.
One is a temporal area, another one is a
Nasal.
nasal area.
Nasal.
Okay, this every eye will have a temporal and normal area, and then the eyes, whatever you are seeing, it will be transported through the optic nerve, and then to the
Yes.
optic chiasma. In the optic chiasma, you will have this decussation of fibers. That is one side of the nasal field, another side of the temporal field will combine
Yes.
and progress into the lateral geniculate lesion. Yes or no? When that is
Yes.
that is affected, you will have a nasal field of your right eye is impaired and a temporal field of your left eye is impaired.
Yes.
Okay, that is so called as homonymous hemianopia. Okay, on the
Yeah.
one eye
Okay.
you have the nasal field impaired, and on the another eye you have the temporal field impaired.
Temporal field.
That is so
Yes.
called as homonymous hemianopia.
Enopia.
So based on the pathway, left geniculate body or right geniculate body, wherever it is going, it is affecting that. Based on the contralateral side, you will see that hemianopia. That's why we see that homonymous hemianopia. Okay. So here in that, if you see the macula is also involved and macula is sparred. Basically, this macula sparing is based on the blood supply. Okay. Whenever during the
Yes.
occipital lobe is responsible for your macula. So whenever you have the posterior cerebral artery blood is blocked, then you may see the macula sparing in that condition. Okay, while if there is a middle cerebral artery is ruptured, you may not have this macula supplied by this this middle cerebral artery. So macula is continuously supplied. So you don't see a macula sparing in that middle cerebral artery, while you see the macula sparing in the posterior cerebral artery blockade.
Yes.
Okay, so it is
Yes.
a pathway defection. That's it.
Thank you, sir.
Okay, anything else? No problem. I'm all about for the answers and questions. In case you have any doubts, you can shoot me. So I literally enjoyed with you people with a lot of questions. I don't know how about you guys.
Yes, sir. We have enjoyed much.
But I see
How these 2
Hmm.
hours,
Very,
how these 2 hours passed, we
yeah.
don't even
We
guess.
literally had a very good time. I feel like we literally
Yes.
had a very good time. Anyways, it was nice discussion with you guys, people. I hope you enjoyed the lectures. If you have more doubts or more things, you can contact the people and they will shoot me the things. Okay. So far,
Okay.
I will go have my dinner because it's only 7 here. So you guys have already had a dinner because it's very late in Nepal, I guess. So thank you. Have a nice
Thank
day, and
Thank you, sir.
see you all in another sometimes, hopefully. Okay.
Okay.
Okay, sir.
Thank you, sir.
Thank you, people. Okay, see ya.
Okay.